good evening, and welcome once again to Building Healthy Families for 2021 and beyond.
Make sure that you're writing your questions and submitting them, because at the end we will have our question and answers.
So tonight, we're going to be discussing the topic of topics: to eat or not to eat. So I wonder if we can find out when we can eat and when not. So on behalf of Mission Hope,
we welcome you
to today's program. Sister Lillian, are we ready to get started?
Yes, let's get started.
Let's begin with a word of prayer.
Let us pray. Dear Lord, as we've been learning about you and how to take care of our bodies to be healthy, not just for today, but for the future, allow us to continue, Lord, to learn and to put to practice, Lord. And Lord, be with each of the speakers and presenters. In Jesus' name we pray, amen.
Amen. Up next, we have a very dear friend to us, Sister Casey Lau, who will be teaching us how to exercise in fun, easy, and simple ways. So Casey, we go with you. The time is yours.
Hey everyone, it's Casey. Thanks for joining me on another exercise segment for today. Today, we're going to be doing an exercise that's going to consist of what we call cardio intervals. Cardio is so good for the body, especially for your heart. Helps keep your heart pumping, your blood moving, and helps to prevent a plethora of diseases. This cardio interval exercise is going to consist of 45 seconds of different movements, followed by 15 seconds of rest. As always, you want to begin your exercise with a warm-up and stretch, which is what we're going to do today. So let's start off with our warm-up. Just walk in place is what we're going to do. Walk in place. It's so vital to warm up and stretch prior to any exercise. Warming up and stretching helps to prepare your body for what's coming next. That way you can prevent any injuries that could occur to your body during your exercise. So after walking in place, we're going to start with stretching. We're going to move on to stretching. So different stretches you can do. These are some of my favorites. I like to always stretch my quads prior to any exercise. You can hold onto a chair, lift the foot, and you'll feel the stretch right here on the thigh. Move on to the next leg, and you want to do that for about 10 to 15 seconds each on each leg. Then we're going to move on to trying to touch your toes down below. And you could also open up your legs, touch down here, move on to the right, and do that for about 10 to 15 seconds each. And you'll really feel that stretch right here in the back of your legs. Some other stretches you can do are your arms. Especially today, this exercise is going to engage some of our arms. So you want to stretch out these arms. You can pull your elbow right behind your head. So our first exercise is going to be standing bicycles. We'll be doing this for 45 seconds, and that's going to consist of just getting your elbow and bringing it to the knee. So we'll do that in 3, 2, 1, and go. So these are standing bicycles. So the key to this is to keep your core engaged. Keep it nice and tight and working at your core. Elbow to your knee. How are you guys feeling? I hope you feel great, because I know I do. We have about 20 seconds left in this interval. So just keep it nice and tight, your core engaged. 10 more seconds. Keep rolling here. We're going to move on to a period of 15 seconds of rest in 3, 2, and 1. Rest. So now is the time if you want to grab some water or just take a breather. Our next exercise is going to be called wood chopper. So we're going to move on in 5, 4, 3, 2, and 1. So with this exercise, it's like you're chopping wood. So kind of put your hands together and with your feet spread out, just like you're chopping wood. And then halfway, we're going to move on to the other side. So just chop wood to the left or to the right, whichever way you prefer. And then we'll move on to the other side. So just once again, with all exercise, you want to tighten up your core, keep your stomach engaged, and just chop away. Chop that wood. We're finishing up this exercise in 5, 4, 3, 2, and 1. Move on to rest. Grab some water. Our next exercise are going to be some pulse lunges, okay? So just while you're standing in place, we're going to be splitting our legs. And in 3, 2, 1, and we're just going to lunge. You can put your hands on your hips, and then this one will be pretty easy. So we're just pulse lunging. If you want to make it a little bit easier or harder, you could always grab a set of weights, set of dumbbells, and just lunge in place. And these are called pulses because you're not going all the way down and you're not coming all the way up. You're kind of just sitting in between. We'll move on down to the next side. And if you have some weights, I'm pretending like I have some weights in my hands, but if you don't, you can just keep your hands on your side and you can feel that burn in your legs. I don't know about you, but I feel it. We're going to finish up this exercise in 3, 2, 1, go. So rest up, 15 seconds of rest. Grab some water if you need to. Our next exercise are going to be some calf raises, okay? So grab something like a chair next to you to kind of balance you out so you can begin the calf raises. And what you're going to do is you're just going to tiptoe. And you can do these as fast or as slow as you want. So you can look at my just tiptoe, kind of keep your body at the center of gravity, grab onto a chair or something to help you balance. And we're just going to tiptoe for the next 20 seconds now left in this interval. How are you guys feeling? You'll start to feel this right here in your calves. We have about 10 more seconds left in this cardio interval. 5, 4, 3, 2, and 1. How do you guys feel? I don't know about you, but I'm definitely sweating. I have my heart pumping, my blood is moving, and you know what? That's exactly great for your body. It may not always be easy for you to start off. It's going to be challenging. It'll be a little bit difficult. But as we start to keep progressing and keep moving, what was harder at first becomes a little bit easier. It doesn't get easy, but it gets easier. As always, drink some fluids, get the right fuel in your body to help you recover, and get ready for the next exercise. Thank you guys so much for joining me on this exercise segment.
Sister Lilium, it's that time of the seminar again. Natural remedies. I've been enjoying it. How about you?
I've been enjoying it too. And the thing is that these are things that we can do at home, that we can learn, and they're simple and they're basic while we wait. When we have an emergency, these are things that we can go to while we wait to go to see our doctor. Why don't we join Tamika and see what she has in store for us tonight?
Welcome everyone. Today we're going to learn about contrast bath. Well, the contrast bath is applied to any area of the body. You're going to immerse one section of the body in hot or cold. So today we're going to focus on facial contrast. So you can have a contrast shower, and you can have a facial contrast. You can have a contrast bath also to the foot. But the principle still remains. 3 minutes hot, 30 seconds cold. Ready? 3 minutes hot, 30 seconds cold. So first thing first, you're going to have your basin with hot water. Then you're going to have your next basin with, you're going to start with lukewarm water. So for the first round of 3 minutes, you're going to go here, place your face all the way in. You can, the perfect thing to do is use a snorkel. If you don't have a snorkel, you put your face all the way in and your mouth out so that you can breathe. So you're going to place this 3 minutes, and after 3 minutes, you're going to go over 30 seconds. And after the second round, the 30 seconds, you're going to put in a little bit more hot water, right? So after you go here and the water is increased, you're going to also increase the contrast in the cold water. So you're going to do this for at least 5 times. So it's 3 minutes hot, 30 seconds cold. After this 30 seconds, you increase the temperature in this hot water. And after the 3 minutes, you also increase the temperature in this cold water. You also need Kleenex because this application is great for persons who are struggling with congestion. So what would happen is that the hot water, it opens your blood flow, right? While the cold water, it constricts. So this is where you actually learn the principles of using hot and cold. So you need this around just in case all the mucus is coming out, and a waste bucket. So it's a very simple yet effective treatment.
It's that time. What section are we headed to now?
We are going to Cooking with the Doctor with Dr. Cooper.
You know, these recipes are just delicious. Have you ever thought that healthy cooking could taste so good? Why don't we go and join Dr. Cooper in the kitchen as she shows us how to eat healthy with delicious recipes.
The doctor's in the kitchen today. You might be wondering why she's in the kitchen. Remember, my goal is to show you how to use food as medicine. And today I have a registered dietitian with me. Estella, welcome.
Thank you, Dr. Cooper.
Estella is a registered dietitian as well as a certified diabetic educator. So she has something very, very special for us. What are we making?
Today we're making Garbanzo Dip.
Garbanzo. What's garbanzo, by the way?
It's also known as chickpea.
Chickpea. Why are we going to be eating chickpea rather than meat?
Well, chickpea gives you enough protein, but it doesn't have any cholesterol.
That's right. Actually, chickpea and legumes, they're known as the poor man's meat. Meat without cholesterol. And we know that red meat is bad for your health. So go ahead.
Yes, we're going to be using today the food processor, and we're going to go ahead and put 1.5 cups of garbanzos. You can make them yourself, or
you can buy them in the can.
Yes, but make sure you rinse them very well.
Pour the water off and rinse carefully, right, Estella?
Yes.
Okay.
We're going to go ahead and put a whole aguacate.
All right, and that has, what are the health benefits in the avocado?
Yes, it also gives you that good fat, which is the omega-3.
Good fat. Mm-hmm. Very good. Let's continue.
Let me just put all the avocado in here.
So good fats you find in avocado as well as nuts.
Nuts, yes.
And why do we need to have good fats, by the way?
One of the ways to lower your cholesterol, you don't have to worry about, raising your cholesterol with this kind of fats.
Right, and you don't have to worry about heart disease. Am I right?
That's right, that's right.
All right.
And I'm going to go ahead and put some lemon juice. This is a whole lemon juice. That makes sure that it doesn't, the avocado doesn't turn brown.
That's right.
We're going to go ahead and add some chopped
onions for flavor. And
cilantro.
Very good. Mexican likes to have cilantro. That's a part of their culture.
Very good. And I'm going to add a little bit of salt. That's your taste. I mean, you can put more salt if you want, but just a little bit for now.
Right. So if you're hypertensive, be careful with the salt because salt will increase the blood pressure.
That's right.
All right, let's go. You want to stop, and then you can stir for the process to continue easier. So let's do that. We're going to stir some more. And at home, if you're making this, don't get frustrated. Just keep stirring until you get the consistency that you're looking for.
Yes.
Okay, let's continue. Very good. Are we almost there?
I guess it depends how smooth you want it.
That's right. I think let's see. I think that's good enough.
I like it a little chunky.
A little chunky for texture. All right, so let's put it here in our container.
We're going to go ahead and pour it in the container. Let me just make sure.
Now, I know that there's some young people, some children that do not like their vegetable. Parents, this is a very good way to get your kids to eat their vegetable by making a very tasty and nutritious dip.
That's it, right. We want to hide them as, you don't want your kids to know what they're eating. consistency is very good.
Okay. So we're going to smooth it in here. And we have some vegetable sticks right here. Now, I have celery and carrot. Why should we have carrots?
Carrots have vitamin A.
Vitamin A. And why do we need vitamin A?
For your eyes.
For your eyes. So you out there, if you want to preserve your vision, vitamin A is the way to go. Estella, we're going to try this later after the show.
Okay.
But you out there, if you want some more delicious recipe, go to my website, gethealthywithdrcooper.tv or cooperwellnesscenter.com. Estella, thank you so much for being on our show today, and I'm sure I'll invite you back another time.
Thank you for inviting me, Dr. Cooper.
And visit our website again, as well as our Facebook page. Thank you.
Sing with us, please. Beloved, I wish above all things that you may prosper and be in good health. Beloved, I wish above all things that you may prosper and be in good health. That my ways may be known above the earth, my saving power among all nations. Beloved, I wish above all things that you may prosper and be in good health. You came to give the more abundant life. Our body is the temple of the Spirit of God. You came to give the more abundant life. Our body is the temple of the Spirit of God. He leads and guides us in temperate ways and keeps us fullness and length of days. Beloved, I wish above all things that you may prosper and be in good health. For a good ambassador is my help, and my health must prosper as my soul prospers. Beloved, I wish above all things that you may prosper and be in good health. Beloved, I wish above all things that you may prosper and be in good health. Beloved, I wish above all things that you may prosper and be in good health. That my ways may be known upon the earth, my saving power among all nations. Beloved, I wish above all things that you may prosper and be in good health.
Pastor Naum, why don't you tell us who's tonight's speaker?
Dr. Guitelle St. Victor. She's a psychiatrist and she also has a family of psychiatrists. You know, she practices medicine in New York in the Nassau University Medical Center, where she is the assistant clinical director for her hospital. So tonight she will be covering the topic, to eat or not to eat.
Good afternoon, everyone. I'm happy to be with you this evening. And as you were announced, I am a psychiatrist, and I want to tell you what psychiatry is about, and why we're talking this evening in the context of building healthy families. So psychiatry is the branch of medicine that is involved in diagnosing, investigating, and treating mental health disorders, mental illnesses. So as a psychiatrist, I do consult. I'm a consultation liaison psychiatrist. And as a psychiatrist, what I do is I do a lot of consults on the medical wards, which you will understand why I am talking about what I'm going to talk about this evening. So as we reflected the whole week on diet and exercise and what we should eat and what we should not eat, what came to my mind when the topics were being discussed is how about people who just cannot stop eating or who are eating because they have an issue, they have a problem, they have a disease. So on that basis, I'm going to share with you today eating disorders, where to eat or not to eat. So please be patient with me. Let me see. I'm going to share my screen. Okay, I think we are on. Okay. Can everybody see? Can
Yes,
somebody?
yes, we can. We can see
Oh,
you. Go ahead,
all
Doc.
right. Okay, very good. Thank you. Okay, so as I said, the title of the topic today is to eat or not to eat. So we're going to review eating and feeding disorders in psychiatry. So before I start, I should say that not everybody who eats or eats too much or doesn't eat necessarily is doing it voluntarily. There's much more to willing or wanting to eat or not wanting to eat. And there are different reasons why people can't eat or eat too much. One of them could be because they have a medical condition. If you have endocrinological issues, thyroid issues, or other endocrinological problems, you will not be able to eat well. If you're on steroids, maybe you will eat too much. Some types of depression cannot eat well, a kind of depression called melancholic depression, and atypical depression is another type of depression where people actually eat too much. So again, if people are eating or not eating the right way, sometimes we have to think that it is not their fault. As such, we want to review this topic today, eating and feeding disorders. Okay, so what is the definition of eating disorder? It's a persistent disturbance of eating or eating related behavior in order to control weight. It's going to result in an altered consumption or absorption of the food, and it's going to impair your physical health or psychosocial functioning. As a matter of fact, it's very prevalent mostly in Western culture. Not that it doesn't exist in other cultures, but in the Western culture, it's very prevalent because of the abundance of food that we have. And also, I put here the pictures that we have of the Miss America, the Miss Universe, rather, in 2009, age 19, 5 feet, 11 inches tall, weighing 108 pounds with a body mass index of 15.1. So in general, in our society, female attractiveness equals thinness, and all of this body image that is in the Western culture is contributing a lot to eating disorders. So is food an addiction? Is it a disorder? What is it? So modernization, evolution of food, especially as I said in the Western hemispheres, overexposure to hyperpalatable food that we have all around us, McDonald's, Wendy's, or every time you pass on the highway, you see that. All of that can contribute to addiction. But eating disorders are chronic psychiatric conditions, and addiction is possible, but as you will see, it's much more complex interactions between genetic, psychological, neurochemical, and social cultural factors leading to some conflicts. And Also, eating disorders are related to behaviors that are developed in order to deal with those conflicts that people have. For example, emotional regulation, problems with self-esteem, their body image, disturbances, relationships, all of those are contributing to eating disorders. So I don't want to traumatize my colleagues with these neuroanatomical structures, bringing us back in the days, but I just wanted to show you that there is a chemical that is called dopamine that is released in the brain when we have a pleasure in something that we do. So the mesolimbic pathway is the pathway where all the dopamine tracks are. So here you have the hedonic hotspots that amplify liking for sweetness. They are all in red, for liking to want to have something sweet. And then you have wanting food rewards are more in green. So I think Dr. Charles Marcel and Dr. Bryce were talking about not eating from the limbic side. So eating more because you want to have control from the prefrontal cortex. So what happens is that wanting food, if you can see in green, all of these pathways. So this is one area that is called the ventral tegmental area. It's part of a section in the brain, that's the midbrain. And then it projects into another important part of the brain that the addiction psychiatrists often talk about, which is called the nucleus accumbens, which is the reward center of the brain. So you have connections going if you are wanting food from one area to the next. But if you notice, they also project to the frontal area, the frontal part of the brain. So the frontal part of the brain is the one that is controlling behavior and is telling you, no, you want this food, no, don't do it. But these areas, the VTA and the nucleus accumbens, is telling you, yes, eat all of this one after the other. So I'm putting this here so that we can see that there's much more of behavior to eating disorders. It's actually in the brain as well. And again, this slide is just to show you that those two areas that I talked before, the VTA and the nucleus accumbens, which is the reward center of the brain. So those two areas, there's a lot of interactions with different chemicals that are released from different areas, different parts. For example, people who smoke, people who drink alcohol, people who use opioids like heroin. There are different ways that these are acting and releasing all these chemicals. So the chemical that we talked about here is dopamine. And then there's a lot of interaction between this area and then feeding into this area. This is cannabinoids here, marijuana. So all of these are telling us that there is a neurochemistry in reinforcement. The more you have, the more you eat these foods, so it's going to produce reinforcement in these areas, and then you will want more and more of these foods. Again, this is the same thing. So what is driving craving? So in the green areas that you can see in the brain, they are all related to preoccupation, anticipation, and craving good food, or craving, McDonald's. And then the blue areas are with binge eating, getting intoxicated with food. And then the other areas that are more orange, they are related to withdrawal. After you had like a large meal, you start having withdrawal, and then there's negative affect associated with it. So food is not just related to somebody wanting or not wanting to do it. There are circuitry in the brain that are related to eating the kind of food that we really should not be eating. So having said that, I wanted to go into the subject. Is it a behavior? As you can see here, all the cookies and all of that. So there are different eating disorders that I wanted to run quickly today. So I'm going to go to different subtypes. We'll review anorexia, bulimia, binge eating disorder, other eating disorders, and feeding disorders. What do they mean? So here is it, anorexia nervosa. The definition is restriction of energy intake relative to requirements leading to significantly low body weight. So what symptoms do we have to look for in anorexia? So you have to think of it in people that you see who have constantly nausea, vomiting, weight loss. The criteria used to say before, it's a refusal to maintain body weight, intense fear of gaining weight, or intense fear of being fat, and therefore there's a disturbance in the way the body is experienced. And amenorrhea, meaning losing the menses, used to be related, so now it's kind of like deleted in what we call DSM-5, which is like the book that we follow in psychiatry. So there are different types of anorexia. The main types is restricting. So those are people who are not eating, they are restricting the amount of food that they're eating. And then there is non-restricting, which is they eat, they binge eat, but then they are constantly purging in order to be able to lose weight. So we no longer say, refuse to eat, or that amenorrhea, not having menses, is part of the criteria, but we say it's much more like pursuit of thinness and wanting to restrict calorie intake. So what signs and symptoms, how do you recognize somebody who has anorexia? So, one of the major problems with anorexic is that they have denial of their illness and they are reluctant to accept that they have problem. Patients tell me, I'm fine, I just don't eat because I don't want to eat, but I'm okay. So they have problems with the menses, as we said, cold intolerance, they are constipated, have fatigue, irritability, cannot concentrate. They have lanugo, which is small, thin hair that is growing on the body. The body temperature goes low, the heart rate goes low, they have dry skin, they lose hair, and they have hypotension, blood pressure is low. Again, the other one that we talk about is bulimia. So what is it to have bulimia? Those are people who have recurrent episodes of binge eating. They are inappropriately using compensatory behavior in order to gain weight. It used to be twice a week. If you would have binge eating for twice a week for 3 months, but now it is only once a week. Once you have these episodes once a week, then you have the criteria, you're meeting the criteria for bulimia. Self-evaluation in bulimic patients is influenced by their body shape, their weight. And then we also have two types. There's the purging type and then non-purging. Purging meaning people who are going to put their finger down their throat after they eat in order to be able to throw up. And all of that is to control the weight. Some of the compensatory behaviors that these people are eating are excessive exercise, laxative use, and fasting. So what happens to bulimic patients? So this is what happens to the teeth because they are constantly, eating and purging. So they have abdominal pain, they have constipation, their menses are very little bit, they have just, not too much menses, they are always fainty, they are weak, and they have the dental complaints, as you can see here, due to the constant acid on the teeth. How do you know somebody is chronically purging? So this is something here on the back of the hands that is called the Russell sign. And these patients also, these people have parotid hypertrophy. So the on the side where the parotid glands are by the neck, those are inflamed. And then the perimollysis is the teeth that I talked about. That's what the perimollysis is. And also on the electrocardiogram, you doctors will see some things that are specific because the potassium will be low. So you see the lady here in the bathroom, she's, she's eating, right? Here's the food, but then she's purging and vomiting at the same time. Okay, so what about the night eating syndrome? That's another type of eating disorder. So you see this lady here, she's here, her fridge door is open and it's nighttime and she's taking a little donut, little snack. So those are people who eat excessively at night. In the morning, they are not hungry. They wake up, at night frequently, 3 times per week, snacking, and then the symptoms have to be present for 3 months. But if they are not meeting criteria for bulimia or for binge eating disorder, they just get up at night to get a little snack. Okay, there's another one that we talked before that is binge eating disorder. I mentioned binge eating. So what is that? Those are recurrent episodes of binge eating in a discrete period of time. And it's like lack of control over eating during that episode. So these people are eating more rapidly than normal when they're not hungry. They can eat until they're uncomfortably full. They're eating alone. And then all of that eating is going to lead to guilt, shame, and patients tell me that, after they eat like that, they're completely disgusted with themselves. So this happens once a week for over 3 months. There is no phobia, there's no problems with the weight or body image disturbances that you have in anorexia, but it's very common in diabetic girls that are age 12 to 19. Some patients are body conscious diabetics. You have a lot of disorders of eating, then eating disorders in some of these binge eating disorder patients. Eating disorder, you can find it also in young diabetics, as I say. So if you see diabetics who are eating large amount of food at once in private, hoarding food in the room, cutting food in small little pieces, eating very slowly, very tense at meal, avoiding the table. These people look thinner, but they wear baggy clothes so that people cannot tell. They have low calorie intake. They go to the bathroom during and after meals. They're compulsively and excessively exercising, and they leave laxatives and diuretics lying around. If you see those, then those are warning signs that your young diabetic may have an eating disorder. So what are some complications of eating disorder? Like, why are we talking about them? Because they are important and they have a lot of complications. So if you're restricting food, number one, you can have, as we said, losing menses. There could be decrease in bone density, dehydration. Edema means that body can get swollen, and these people can get kidney stones. If you're binging on food, you can get obesity. Obviously, you can get swollen, and we have seen stomach dilation to the point that somebody's stomach ruptured at some point in time. We have seen it. I'm not exaggerating. And if you're purging, so you're more likely to have vomiting, electrolyte imbalance to all the electrolytes will not be in place. The tooth will be decaying. You will have throat and mouth sores, muscle weakness, and using diuretics, you'll have cardiac issues, and using diet pills puts you at risk of having heart attack, seizure disorders, increased blood pressure, and also CVA. Those are the risk of eating disorder. CVA is a stroke. So those are medical complications of eating disorders. So we mentioned bone density, right? In the previous slide, I said bone density. So a quick word on bones. Half of young women who have anorexia, they have osteoporosis. So fragile, brittle bones. And that's why we recommend that every patient with anorexia should have a bone density test done. And some of them may be able to recover. Calcium is needed, and vitamin D is needed as well. So you may be thinking like, well, all of that is, it's nice, but how do you treat these eating disorders? So the treatment is a biopsychosocial approach. What do I mean by that? So the first thing that we always tell patients that have eating disorder is that they have to have a therapeutic alliance with a doctor. Well, if it's their primary care doctor, that's fine. Eating disorders are, like I said, chronic psychiatric conditions, and they have relapses. The patient can do well for 1 year and then later on relapse. It's like treating diabetic, high blood pressure. So they need to be treated by psychiatrists, by a team of psychiatrists and social workers. So it's multidisciplinary team. So what do? We need to identify signs, symptoms of eating disorders that I just shared with you, the teeth and the body and all of those that I shared before. And those internists are going to do good physical exam. Like when you walk into Dr. Cooper's office, he's going to do a good physical exam for you. And we also in psychiatry, we need to elicit family history, because people do have eating disorders in their family or other psychiatric conditions. Also, we want to know what are the family's attitudes to food, to appearance, to exercise. If all the time in your family, everybody is talking about food all the time, so that, that's the environment you live in. Usually these patients are very secretive, and I can even say that they are somewhat, sometimes can be even deceptive. And just the thought of food sometimes produces anxiety in the patient. And then, when I see the patient, we put the tray of food in front of the patient, and they're like either become nauseated or they become anxious, start having palpitations. So anxiety, just about looking at the food, is something serious that we have to assess. So how do we assess? I said the multidisciplinary team. It includes gastroenterologists, internists, psychiatrists, psychologists, social workers, dietitians. We just heard the dietitian just a few minutes ago. Everybody has to be together. Dentists, everybody has to be together, work together, and have mutual respect for the patient and for each other. Why do we need to treat eating disorders? Look at the anorexia mortality rate. 44% of patients, if treated, they do good. 24% do very poorly. 28% are somewhat in between, but 5% of patients will die from an eating disorder, especially the anorexic ones. So it's it's a serious illness, it's a disease, and we need to take it seriously and treat it. Is there a role for medication? Yes, there is. So anorexia nervosa, most likely they will have rehabilitation, nutritional rehabilitation therapy, and there can be medication. But in bulimia, the FDA has approved a medication that you all are familiar with that is called fluoxetine, that is Prozac, 60 to 80 milligrams. And I know that question will come, so I just put it in because I know somebody's going to say, why do we need medication? So the reason why the FDA approved it is because it's been proven that at least 60 milligrams of fluoxetine or Prozac will decrease the binge eating episodes that I talked about, the purging, the anger trait that is associated, the impulsivity. It's been proven, but you have to do 60 milligrams, not less than that. There's a medicine called Wellbutrin. It's contraindicated in eating disorder patients, and patients may need to go inpatient. I'll talk a little bit about that. And there are other medications like topiramate or lisdexamfetamine that are also used for binge eating. So what is the evidence-based treatment that we use in psychiatry? So again, for bulimia and binge eating disorder, we recommend different types of therapy. For anorexia nervosa, that's actually a question for my medical students. We always have that question. What is the best treatment for anorexia nervosa? It's family therapy and thin soup. So you can see the soup on the side here, thin soup, because sometimes people don't really want to eat like heavy meals. So they want to have, very days without eating. So that's not acceptable. So at least thin soup, there are electrolytes liquid in there. So we want family therapy and thin soup. I'll say a little bit more about that in a next slide. So these patients also need behavioral weight loss therapy. But here is really what I wanted to say about treatment for anorexia. So these people, they need nutritional rehab. So if you have an anorexic, that you know, a friend or one of your patients or one family relative, and you're just telling them, eat, it's okay, you can eat, why can't you eat? I just see a lot of people say that. Here's a banana, just eat it, why can't you eat? That's not going to help that person, okay? They need rehab. Just the same way when you break a bone, you go to rehab, these people need nutritional rehab. What is the goal of rehab? is to restore their weight because you saw the consequences of not having the good weight. So they need the rehab to help normalize their eating patterns. And one thing that I thought was very interesting, they also need rehab to help them to learn normal perceptions of hunger and satiety. So these people, they don't know what hunger is. They don't know when they feel hungry. They can't interpret it in their body. They also, people who have binge eating or bulimia, they cannot interpret when they when they are full. They will keep on eating. So the nutritional rehab is going to teach the patient, the person, how to perceive when you're hungry. How is it that, this little sensation in your stomach, it means you're hungry and it's time to eat. Or that sensation in your stomach means that you're full and you need to stop. So why do we say family therapy and thin soup? Family therapy, you would say, what does the family have to do with it? Yes, the family has a lot to do with it. Like I said before, we assess what is going on inside the family. So parents have to assume responsibility for the anorexic children. It is not the child's fault necessarily. Everybody has to take responsibility. It's a family dynamic. Refusal to eat is not an option. You have to teach the person, we are going to sit at the table, you cannot not eat. However, you're going to take contingency, which is a thin soup. And we have to understand and remember that anorexia nervosa is nobody's fault. It's a disease, it's an illness that involves everybody, the patient and the family, and it needs treatment. So what levels of care, where do we treat these people with eating disorders? So they can be treated as outpatient. That means in Dr. Cooper's clinic, she can have, in a clinic, the patients are there. If there's a psychiatrist there, so from the level of psychiatric care, we divide it in four levels. So the patient can have outpatient, they have an appointment, they go to the clinic, they come back. There is also what is called a partial hospitalization, where the patient is partially hospitalized, but then they go home. And then there is residential, where they actually live in a place where they're going to control their weight. They're there for 3 months, 6 months. Okay, when it's really severe, the patient goes to the residential and they stay there. They don't go home in the evening. And then there's the inpatient. There are some inpatient psychiatric units that are specialized for eating disorders. So it depends on the severity of the case. When we do a psychiatric consult, together with the social worker and the medical team, we'll decide which level of care is better for this patient. So when do we hospitalize? We hospitalize patients. I'm talking about involuntary hospitalization against the patient's will. Why? Because it's reached a level where it's dangerous. For example, when the blood pressure is going to go below 90, when the person is very dizzy, low body weight, the pulse is low, less than 40, okay? Your glucose level, sugar is less than 60, potassium less than 3, very low temperature. When the person has kidney, liver, cardiac compromise, suicidal patients who want to die, less than 75% of body weight, patients who are not motivated, have poor insight, they don't understand their disease, or they don't want to cooperate. If there is instability in the family, in the psychosocial environment, that's when we do involuntary. But when we kind of like twist the arm for admission is when the patient is losing weight very rapidly, their electrolytes are low, they have kidney damage, they're using other products, they have very low BMI, and when, listen to this, when nobody's home, that means the child or the adult, the young adult, there is nobody there to support. There's no one to help that person. So that person, we're going to have to twist their arms to come into the hospital to get treatment. The BMI, I'm going to skip on this because I know that, Dr. Charles Mason and Dr. Bryce spoke about that. Body weight ideal is 100 pounds plus 5 pounds above 5 feet, more or less 10%. And I just want to say, if you have above 30, you're overweight, and above 40, you are or morbidly obese. Less than 17 is the anorexic range. Okay, I did say that some patients use laxative in order to lose weight, but there's a consequence to laxative. And I'm saying, I put that slide in because, I hear a lot of people in church, in the community saying that, oh, you want to lose weight, just use the Chinese tea. And then, it's a laxative. It will help you to lose weight. It will give you diarrhea. So I just want to warn us that laxative abuse has complications. On the left-hand side, you can see constipation, dehydration, electrolytes will be imbalanced, you will be bloated, you will be swollen, and you will not have a good bowel function. The bowel is supposed to be used by itself. It's not supposed to have a laxative to help it to move. And then on the other hand, if you're constantly using laxatives in order to be able to have a bowel movement, the day you stop it, you're going to have laxative withdrawal. On the right-hand side, you will have constipation, you will retain fluid, you will feel bloated, and you will have temporarily your weight gain. So when do you stop abusing laxative? It's just like what we tell patients about smoking. You stop now, right now. Don't make a plan to stop in 2 weeks. Stop right now. Drink 6 to 10 cups of water. A lot of physical activity is going to help you. Eat regularly. Eat food that will increase bowel movement. And if it's really bad, you may want to talk to your doctor or try suppository triglycerin, but discuss with your doctor first. And you will need to enter into a bowel training program. I did say that, eating disorders are problems of the family. So what are psychosocial? So we talked about the medical complications, but there are also psychosocial complications of eating disorders. So as I said before, these patients are secretive. They are, anxious, just looking at food. And as you can see, as you know, eating together in the family is a pleasurable activity. But when you have somebody in the family that has an eating disorder, then it becomes a problem. This person is going to be lonely, is going to feel ashamed, is going to feel disgusted. And a lot of people kind of like put up living until they become thin. I talked about what, the Miss America and Miss Universe context. A lot of these patients, they say, I can't do this, I can't do that, I can't get married, I can't have a boyfriend, I can't go out with my family, we can't go on vacation until I become thin. A lot of people have spiritual issues. They feel very, extremely, extremely guilty. And they shortchange their family, their partners, their children. They are not there when there is family dinner. They escape in their room. So there are a lot of psychosocial complications to eating disorders. What about if you're pregnant? If you're pregnant, is there a problem? Yes, there is. The risk is the babies are at risk of not being born at all. They could be miscarried, or they could be born small and premature. So the mother, if the mother needs admission and the mother has symptoms that cannot come under control, we actually are going to hospitalize them, and we're going to strive for restoration of weight, and in the non-pregnant patient or before pregnancy to restore menstruation and ovulation, which are all affected by eating disorders. There are other eating disorders that I'm not going to go into detail. I just want you to know there is one that is called ARFID. That's avoidant restrictive food intake disorder. Those people also have a lot of underlying anxiety disorders and other medical conditions. They have underweight, but they don't meet criteria for those that we talked before. And also there are feeding disorders that I wanted to talk about. One of them is pica. So some people don't eat food, they eat other things. They eat chalk, they eat clay, they eat cloth, coal, dirt, gum, they eat hair, metal, paint, paper, pebbles, soap, string, or wool, non-nutritional, non-food substances. Eating that for at least 1 month, that's a behavior that is inappropriate for the patient's developmental level, not supported by the culture or by the societal norm. And if it's happening in the context of an other mental disorder like an autistic disorder or intellectual disability, which is the new name for mental retardation, or schizophrenic patients, or in patients who are under, pregnant. So if it's severe, it needs additional clinical attention. So this is an example of a trichobezoar, which is a giant mass of hair that was removed from a patient who was swallowing hair for a long time. Quite impressive. Rumination disorders, so those are people who have repeated regurgitation of food. So the food is re-chewed, re-swallowed, and spit out, doing that behavior for at least a month, but it must not be due to something like acid reflux or another of the conditions that we talked about before. If it's happening severely, it needs additional attention. There are others if you don't have something specific that we talked about, so you could have specified or unspecified eating disorder. I thought that I cannot talk about an eating disorder without talking about psychogenic vomiting, because we see it a lot in the hospital. 20 to 40-year-old people who have chronic episodic vomiting, they are vulnerable to vomiting when they are under stress. The vomiting starts as soon as the meal starts. When everybody sits to eat, that's when the vomiting starts, but they can suppress it. There is no nausea, abdominal pain. They can induce it just by touching lightly the abdomen. Physical exam is normal, but there's probably some history of childhood vomiting in the context of separation. These people, you will see the family is not concerned. The family said, oh, yeah, she does that. She kind of like sees the food and throws up. So once you see that, then we know that it's psychogenic type of vomiting. And, the patients, what happened to them is that they have angry feelings that are displaced toward vomiting. Instead of yelling at mom or at dad, I'd rather vomit because that helps me to relieve my emotional stress and gives me comfort. And then I get relief afterwards. So those people have difficulty dealing with anxiety or anger, or setting interpersonal limits or saying no. So they need treatment mostly with therapy. There's a role for medication for anxiety, but mostly it's helping them to deal with their stress, and they have to clean up their own vomit. Nobody does it for them. So as a conclusion, I want to say that eating disorder do exist. As we saw, it could be related to brain pathways. It's behavioral, it's familial. Not everyone who eats or does not eat does it voluntarily. Some eating problems are due to mental disorders and diseases, and the biopsychosocial approach is the way to go. So sometimes we recommend for people to have identify their triggers by keeping up a food journal, and then to enter into therapy. And sometimes in therapy groups, they recommend locking the refrigerator at night so you won't be tempted. But the best treatment is always therapy, a specific kind of therapy that is called CBT. It's cognitive behavioral therapy, to help change the way you're thinking, and also your behavior changes right after that. So, you're wondering where's the biblical application. So here it is. There's food all over the Bible, and I'm sure that the pastors listening agreeing with me. Eli was fed by ravens, so there's no problem with eating. Jesus ate. Okay, he was hungry. He knew when he was hungry. He was able to identify his perceptions of hunger. He ate. He fed the disciples. He fed the crowd. He knew when to fast. He chose to fast when he needed to have a closer communion with God. But guess what? Satan also knows about food and about all of these things that we talked about. He used food in the desert to tempt Jesus by asking him, change these stones into food. So the food is not the problem. Eating is not the problem. It's all across the Bible. And there are people in the Bible who also could not eat because they were depressed, because they had, there's depression all across the Bible. There's anxiety in the Bible. So we have all of these applications in the Bible. It's just a matter of us. What do we do with the knowledge that we have acquired today? That's my question. What do we do with the knowledge that we have acquired for all this week? Whatever you do, says 1 Corinthians, whether you eat or you drink, you do it all for the glory of God. But I wanted to say, there is another verse that says, you will also know the truth, and the truth shall set you free. So the reason why I put this there is because I want us to remember some people don't eat well, or they overeat, it's not because they don't want or they want, it's because they have a disease. So if we know that it is a disease, it's an illness, then we will know the truth. And if we know the truth, then we will be able to look for the proper help for that person in order to be able to get that person proper treatment that they need. If the Son frees you, you are free indeed. That's one of my favorite verses in the Bible. I want to thank the Mission Hope 70 Adventist Church and Dr. Donna Cooper Dockery for this invitation. It was a pleasure being with you this evening. My most sincere thanks to my very good, awesome medical student, Chupunonso Azubogo. He has done a lot of research, and the beautiful pictures that you see in this presentation, I really want to say many thanks to him and to everyone who is listening, the church and everybody else. I really wish for all of us to be in good health, and may we all prosper just like our soul, our mind, our mental health prospers. Thank you very much. Now, what do I get out of?
Doctor, I have 2 questions for you tonight. I was very impressed with your presentation, but I have 2 questions. These eating disorders that people have, would you say it is the fault of the person to have an eating disorder?
Okay, like I said earlier, I think, you know, we have to, it's a good thought, because we always think that it's somebody's fault, right? And we tend to blame the person who has the eating disorder. We tend to say, why don't you just eat? All you need to do is to eat. Or why don't you stop eating? All you need to do is you're eating too much, just stop. So it is nobody's fault. Anorexia is no one's fault. Bulimia is no one's fault. It is a disease. It's a brain disease. It can be an addiction, and it can be a behavior. It needs treatment. It is not somebody's fault.
So what would you say, Dr. St. Victor, is the best treatment for eating disorders?
The best treatment for eating disorder has to be a biopsychosocial approach. So if you use medication alone, it's not going to work. If you use the psychology alone, it's not going to work. Okay, the therapy may work. That's probably the best way to start. But some, as you saw, some patients are so sick that they need medication, they need the therapy. In general, what we recommend is all of it together and family therapy. We believe in psychiatry that that's one thing that I should add, that you know, all these eating disorders, there's a lot of issues of control on these eating disorders. So the best way for me, if I lose control in my house, that whatever the reason, let's say, you know, somebody, for example, I'm the last child and nobody's paying attention to me. Everybody is running around paying attention to all the older kids, and I'm the last little one and nobody pays attention, and I end up having an eating disorder. It's about control. The best way for me to regain control is to stop eating, but it's unconscious. It's not something that the person is doing voluntarily.
All right. Thank you so much, Dr. St. Victor.
Yes,
Thank you.
we actually, thank you so much for that. We had a question that came through on the Facebook message section, so I thought that we'd ask that before we go into our next portion of the program. The question was, and I'll ask you, Dr. Brown, what is the difference between hemorrhoids and polyps? It's in regards to the topic that we gave yesterday about colon cancer.
Okay, hemorrhoids. Hemorrhoids are engorged blood vessels, which are generally found in the lower part of the rectum and the anus. They can be internal, meaning that they're inside and you don't see them. They may also be external. That means they're on the outside. So if you are to take a look at the anal area, then you will see little, like little lumps hanging down. Those are hemorrhoids. Then polyps are fleshy growths, which develop on the lining of the colon. Polyps can be found in other parts of the body, but we're speaking about colon cancer. These are fleshy growths. They don't have bone inside of them. They would look like the head of a finger, for example. Some of them are on a stalk. Some of them are just flat and look like a mushroom, the head of a mushroom down on the lining of the colon. These two conditions can cause bleeding. And some people who have bleeding from the rectum will assume that it's only a hemorrhoid, but this is a very dangerous area. If you see bleeding in your stool, you cannot just assume that it's from hemorrhoids. You need to get it checked because you could be bleeding from polyps or from some other serious condition in your colon. I hope that answered the question.
Yes, thank you so much, Dr. Brown. All right, so we'll get back to our regularly scheduled programming. Thank you.
We want to thank Dr. St. Victor for teaching us the answer to eat or not to eat. So, Sister Lillian, what do we have up next?
Up next is the section Conversation with the Doctor. We have the opportunity to speak to Dr. Chang Brown. At this time, we'll turn it over to our doctor, where you get to have some Q&A.
Good evening and welcome to another episode of Health Turbine, powering the drive to impact wholesome lifestyle choices. This evening, our topic will be diabetes. Diabetes, whether type 1 or type 2, is probably the most underappreciated, misunderstood, and most poorly treated of all common medical conditions. It's very common. Over 30 million Americans are affected by this disease, and they're paying dearly with their lives and with various aspects of their health. In Texas alone, there are almost 3 million diabetics. That's almost 15% of the population of Texas. Moreover, 650,000 have pre-diabetes or have diabetes. That's a mix, and they don't even know it. Tonight, we have Gwendolita with us, and we're going to hear their experience with diabetes. I'm Dr. Marlene Chang Brown, and welcome. Gwen, as you're well aware, McAllen has the infamous title of being the fattest city in the United States. On the college campus where you work, have you seen that this condition affects the younger people? Or is this just something that affects older, inactive adults?
It is not just, young adults, children, and older people, right? But I come across so many students, and a lot of them are overweight and obese. But the thing is, they do not realize that they are obese or overweight. For example, I was talking about BMI in class, and this morbidly obese student says, "Do you mean I am obese?"
What are the main factors that impact this trend in the Rio Grande Valley? We could probably extrapolate to the rest of the world. In your workplace, for example, is there something that strikes you? Is there something that stands out in particular?
When I looked at the categories of how they ranked McAllen as the most or the fattest city, I looked at the categories, and they were obesity and overweight, inactivity, and food and fitness. And then the other category, the third category, is health consequences. Okay, and McAllen ranked the first in two categories, and the third on fitness and food. Okay, the same things we see all over the world, those are still the same factors. Okay, what I see in my students is the stress, okay, of being a student, especially the rigorous nursing program. So they do not exercise, they eat while studying and just eat junk food. Mm-hmm. And so stress is a big factor there that I see.
Are there any words of wisdom that you would like to share with someone who may be struggling with this problem?
Yes, we need to realize that there is a problem. That's the first thing. And then there's a need to seek professional help. Just don't go on any kind of diet, mm-hmm. You know, the popular diets that are advertised. Seek professional help, an expert in nutrition and weight management, that sort. And definitely seek God's help. He will fight your battles for you.
All right. Good evening, everyone. So we just talked a little bit about obesity in that short snippet. And of course, individuals who are obese have a higher risk of diabetes, which is the topic that we're going to be talking about tonight. About 400 million people worldwide, that's about 8% of the world's population, have diabetes. So let's jump right into the questions, shall we? Dr. Brown, thank you so much for joining us again this evening.
You haven't mentioned our ribbons.
Oh, I didn't. I forgot. So we're wearing gray ribbons today, and gray is the color for diabetes awareness. Sometimes they have a little red heart on them as well, but that is why we're wearing green ribbons. Gray ribbons this evening. All righty then. First question. Dr. Brown, what is diabetes? I heard that there are different types, like type 1, type 2. Are there any others? And can you give a little bit of explanation?
Well, simply put, diabetes is high glucose in the blood. That's the simplest way that I can put it. And there are various different types. The most common types are type 2, type 1, and gestational diabetes. Type 1 diabetes is what we would call in the past the juvenile diabetes, because that was more common in the younger people, children and young adults, youth. It is no longer called juvenile diabetes because older people can have type 1 diabetes also. Type 1 diabetes accounts for only about 10% of all the diabetic cases. Type 2 diabetes is much more common, and if you're an adult, then that's generally the type of diabetes that you have, although we say you might also have type 1. Diabetes in and of itself results when the body does not produce insulin, as in type 1, the pancreas, which produces insulin, completely shuts down. There's no insulin production. And so those persons come to the front, come to the fore much quicker because their body systems just completely go out of whack. They have no insulin. They're diagnosed early. Type 2 diabetics may have diabetes for years and may not even know it if they don't go and get checked. This is why many times we have health fairs and we invite people to come over and have their blood glucose levels checked. So type 2 tends to be more insidious, comes on, and it may be there for quite a while before people discover that they do have it. So what's the problem? Either there is a reduction in insulin production, and so the role of insulin, I should mention, is to move sugar or glucose from the blood into the cells. If there is less insulin produced, then this movement of glucose from the blood into the cells is reduced. So there is a higher level of glucose in the blood. And the other problem is if the cells themselves are not sensitive to the action of insulin. So insulin is saying, open up, I need to get the sugar into your through the door, but the cell says no, or the cell doesn't. It's like someone who is hard of hearing. So the cell is not sensitive to the action of insulin, and that causes sugar to be built up in the blood. And the insulin levels in those people may actually be higher than normal. We call that hyperinsulinemia, and also insulin resistance.
All right. You did not mention gestational diabetes.
Oh, thank you.
Please expound on that.
Yes, thank you for reminding me. The patients who have gestational diabetes, as the name suggests, they're usually pregnant. They have not had a diagnosis of diabetes before their pregnancy, but during their pregnancy, they develop high blood glucose levels in the range of diabetes. These ladies, many times, they go back to being non-diabetic after they deliver, but some of them have the risk of continuing on as diabetics even after the pregnancy.
And are there risks to the baby as well?
Yes, there are risks to the baby. They generally are high birth weight babies, so they're larger babies, most of them over 8 pounds. I've seen them up to 11, 12 pounds, really huge. When they're born, they seem as though they have been already around for 3 months. They may be stillbirths, so not very good. Then some of these babies may go on later on in life to develop obesity.
Right. Which also puts them at a higher risk of diabetes as well.
Yes.
Right?
Yes.
So talking about these risks then, what are the risk factors associated with diabetes? We talked about type 1 being more of an autoimmune issue, but what about type 2 diabetes? Or can you explain that a little bit more?
Yes, there are several risk factors, and I know that people tend to say diabetes runs in my family. It has been said that family history will load the gun, but it's actually our lifestyle that will pull the trigger. So you may be predisposed to it, it runs in your family, but if you do what you need to in order to prevent this from developing, then you don't have to get diabetes just because your parents have it.
Okay.
Other risk factors would be ethnicity. Blacks, whether American Blacks, Caribbean Blacks, Southeast Asians, they have the highest risk of diabetes.
Weight, right?
If you are overweight or obese, the overweight people have less sensitivity of their cells to insulin. So that's another risk factor.
Okay. So what symptoms may individuals have that may clue them in that they possibly have diabetes?
One of the first symptoms that people may notice is that they start feeling tired, just not able to explain what it is. And it may be because they're getting dehydrated. They are very thirsty, but pass a lot of urine. And as you know, the body is made up 70 to 80% of water. So if you are passing a lot of water, your body weight is going to go down. That is one thing, one symptom that patients may develop: loss of weight, tiredness or fatigue, excessive thirst, and increased urination. Another would be blurred vision.
Okay, so all things to look out for. And we talked about hypertension being a silent killer. I would also venture to say that diabetes is also a silent killer, because as you said, you can have diabetes for a while and not even know it. What are organ systems that can be affected by diabetes, unbeknownst to the individual, that can cause problems down the line?
Well, things that you might not be aware of. Let's start at the head, say in the eyes. Cataracts. Early cataracts you might not be clued into, but if you're diabetic and your vision is starting to get dim, cloudy, looks as though you're looking through a cloudy pane of glass, you may be developing cataracts. There's a strong association between diabetes and cataracts. But more importantly, diabetes may affect the blood vessels in the retina of the eye. When these blood vessels proliferate, they are not as strong as the original blood vessels. They are very weak and they tend sometimes to rupture. So the eyes have to be examined quite regularly. If these blood vessels are seen, then they're usually photocoagulated. People will say, I had laser treatments to my eye. That's what's done. They burn these blood vessels so they don't rupture. If they rupture, then blood fills the eye and the person just cannot see, the light cannot penetrate.
What about the heart?
Oh yes, the heart. People who are diabetic are 3 times more likely to die of a heart attack than those who are non-diabetic, because by and large, diabetes is a vascular disease. It affects blood vessels all over the body. So heart disease is one of the problems of the diabetic.
I know that a lot of diabetics have numbness in their feet, in their hands. What system does that affect? Why do they have that?
So it also affects the nervous system. The longest nerves in your body are those that travel from your back down to your feet, to the toes. And so those are the most early affected, I would say, by diabetes. Numbness starting in the toes, creeping up the legs, sort of a glove and stocking pattern to that, what we call neuropathy or nerve damage. So starting in the toes, coming up, by the time you get to mid-leg, the neuropathy is starting also in the fingers. Some people cannot feel anything with the hands, or the hands are very numb. They may handle a hot pot and they might not even feel it. They may get burnt, so those people cannot be allowed to cook. The same thing with the feet. You might get injured and not even know that you have a nail injury, or you may have stepped on a thorn and you might not have picked that up.
All right, so that's why it's important that diabetics should always check their shoes before they put them on. Also check their feet as well to make sure that they don't have any cuts, and making sure that they always wear shoes, because if they can't feel well, then there's a risk that they can injure themselves.
Yes, and when you say check the shoes, actually shake them out, because you might have little stones, little thorns, anything there that you don't feel, and it will constantly rub against the skin and cause an ulcer. And by the time you find it out, it might be something that's advanced.
Okay. And I know a lot of diabetics also have amputations.
Oh, yes. Amputations, that's a very scary thing. But amputations come about because of mainly 3 things. There is the problem with the nerves, so you don't feel the injury. Normal people, well, non-diabetic people, if they have injuries, they generally will have good circulation and these injuries heal easily. A diabetic might not have good circulation. When I say this, not all diabetics have poor circulation, but they're at greater risk for poor circulation. So if you have an injury and poor circulation, then the healing may be delayed. On top of that, diabetics who are uncontrolled are also immunocompromised. They tend to have more infections. They're more susceptible to infections. And we saw that with the COVID pandemic, that many of the deaths were in people who are diabetic. So the injury, the poor blood flow to it, then the infection coming into the wound that won't heal, then that infection may move from the skin into the soft tissues, then into the bones. And as much as you treat sometimes, then even the antibiotics do not get to the area because the circulation is so bad and the medication cannot get to where it needs to. The leg has to be removed just to save the person's life. Some people say, no, I'm not going to have an amputation. But when it gets to the point that the infection is taking over and it's in the bloodstream, they're starting to get a bit confused. Then they say, okay, do whatever you need to save my life.
Okay. And lastly, in regards to organs affected, we've talked about cancers. Are any of the cancers that we discussed also associated with diabetes?
Yes, we mentioned in earlier nights, the colon cancer, breast cancer. There are other cancers such as liver cancer, which may be increased in diabetics, pancreatic cancer also. We can't forget the kidneys.
Okay. We forgot to mention how diabetes was diagnosed.
Oh, first let's talk about the kidneys, because many people are afraid of dialysis.
Oh, yes, yes, dialysis.
Dialysis and kidney disease caused by diabetes is the most common cause of dialysis. In the Rio Grande Valley, because we have so many diabetics, close to 10% of our population here is diabetic, we see dialysis centers popping up on every corner. It's a very sad thing. I'm happy that we have the resources to take care of our patients, but it is sad that so many people need these services.
Yeah.
On to your question now about, what was your question?
How is it diagnosed?
How is diabetes diagnosed? You cannot look on a person and just think that they're diabetic. Generally, you need to have a blood test. In the old days, we used to check the urine, but that's no longer used as a standard test for diabetes.
They would taste it, right?
They would taste it, and sometimes in some rural areas where people may urinate outside, or they may throw their urine from a receptacle outside, they would watch to see if ants would go. And if you see a lot of ants around the urine, it may be an indication that there is sugar in the blood, sugar or diabetes. But the way we diagnose diabetes nowadays is by blood tests. There is the random blood glucose, which is checking your blood sugar after eating. This, we try to do more of fasting levels, but if you have to have food before you eat and you check your blood sugar and a random level is over 200, then that may be an indicator of diabetes. You need 2 tests to say that the person has diabetes. So just one random test may not be enough unless the patient has symptoms. So if you have symptoms, you go to the doctor, you're having increased urination, you're very thirsty, you're losing weight, and your sugar level is over 200, they do a finger stick. They're going to tell you right then and there that you're diabetic. Yes, they're not going to be waiting and saying, come back after 2 weeks or a month, because in that time, there's more damage being done to your organ system. So that's one test. Then there's a fasting blood glucose level. Once your blood sugar level, fasting, that means you haven't eaten overnight, you have the blood checked first thing in the morning. If it's over 125, then that's in the diabetic range. And lastly, we have a test called the hemoglobin A1C, which gives us an idea of how the blood sugar has been for the previous 3 months. Some people like to trick the doctor. They stop eating a week before their blood tests. And when they come, you say, oh, your fasting sugar is good. It's 100, 110. But then we can see from the hemoglobin A1C what has been going on for the previous 3 months. And if that test is greater than 6.5, or should I say 6.5 or greater, that's also in the diabetic range. So if you have a blood test and you have, say, a fasting sugar of 130, and you have a hemoglobin A1C of 6.6, we don't need any further tests. We have we have 2 readings right there. The person is diabetic.
All right. Lastly, are there any lifestyle changes we can make to decrease our risk for diabetes?
As we have heard every night, all the principles remain the same. Exercise, exercise, exercise. Eat healthy, eat healthy, eat healthy. And what was the last one?
There was something about a low glycemic index in regards to the foods.
Oh, foods. Okay. So some foods are better for diabetics than others. Some foods, basically all foods that you eat are broken down in the end to glucose or some simple sugars. Glucose, also called sugar. Foods that break down very easily and give you a rapid increase in blood glucose, those are called high glycemic foods. So some of those would be your processed foods, your simple sugars, you have
Cereal,
ice cream, some of those sweet cereals, not to mention some people think they have that fruit juice is very healthy. It's not very healthy. It's better to eat the fruit because everything is all ready to be digested. You don't have most times any of the pulp there unless you just blend it up and eat it. But most people filter out the pulp, so that fiber, which retards the absorption of sugar, is not in there. And sugar gets absorbed rapidly, the level goes up quickly, and that tends to raise the blood sugar levels.
Okay. All right. And then sleeping is important as well.
Yes, sleeping. If you sleep just a little, then you're going to have more of the hunger hormone called ghrelin. Ghrelin will make you feel very hungry and you will have to eat and eat and eat. So as Dr. Bryce pointed out last night, we need to rest well. We need to get our full night's rest. This will directly impact how much we eat the next day. And that will be important in either preventing or controlling diabetes.
All right. Do you have any last thoughts?
Yes. Somehow I think I forgot something in the last question. I can't remember what it was. It was about the foods with a low glycemic index before my last thoughts. Okay. The foods with low glycemic index, you have to eat your nuts, you have to eat your green leafy vegetables. There are certain fruits which are not very sweet that you can eat. Do you know that even sweet potatoes are good for diabetics? They're very fibrous. So just stick to the regular health principles that you have heard all week. Now for my final thoughts. There was a wise man in the Bible called Solomon, and he gave us some good advice. In Proverbs 25, verse 27, he said, "It is not good to eat much honey." He already knew that it's not good to dwell too much on sweets. And he again said in Proverbs 6, verse 6, "Go to the ant, thou sluggard. Consider her ways and be wise." That means watch what you eat and exercise. And those are the two most important formulas for prevention and control of diabetes.
Thank you so much for this wonderful information regarding diabetes. I'm sure that we've all learned a lot. I have a Blue Zone quote to end. "Undoubtedly, the most desirable sweets are those to be found in fruit, either fresh or dried. These are the harmless sweets provided for us by the Creator, which will never clog the system." This has been
Health Turbine, powering the drive to impact wholesome lifestyle choices.
Once again, we thank you for joining us today.
I hope that we have all been learning through this week how to build healthier families for 2021 and beyond.
Don't forget to invite your family and friends to join us.
So at this time, we're going to be closing with a prayer.
Dear Lord, we thank you for everything that you've taught us tonight. Allow us, Lord, to continue to practice it, Lord, what we've learned, and allow us, Lord, to be healthier for now and the future. In Jesus' name we pray. Amen.
Amen. Happy Sabbath, everyone. We'll see you tomorrow.